I know that you cannot see me from there, but I will try to do my best. So today my task is to talk a little bit about the natural history of a rotator cuff tear. So these are my boring disclosures, and these are my true disclosures. So I have to disclose my deep friendship, and I'm very thankful to be here. So thank you, Manos and Manos, for having me again. I always have so much fun in this Athens shoulder course. So let's go to the serious part of this. So what is the natural history of a rotator cuff tear? What does this mean? And why is this important? And how can it be applicable to our day-to-day practice? I think this is the most important thing. So the literature is vast. You have a lot of information about this. So let's try to somehow organize this in our minds. So first of all, we're going to ask ourselves, who's our patient? Who's in front of us? Then what's exactly the type of tear that the patient has? And the third point, what is our goal? Our goal as a surgeon and our goal with our patient. So the first point, who's your patient? So we know that the literature tells us that there's an increased probability of rotator cuff tear when there's a male gender, when there's a dominant shoulder, when there's an increase in age and a heavy labor-related patient. So we also know by the literature that the rotator cuff tear progresses more in a patient that was 60 years old of age or more. Also, we know that dominance is related to tear enlargement, and we also know that a painful cuff tear in a 66 years old or more patient has about 50% chance of having a contralateral rotator cuff tear. Then what's the type of tear? You can have an acute traumatic tear, you can have a chronic degenerative tear, you can have maybe an acute and chronic. Relating to the morphology of the tear, you can have a partial thickness tear, you can have a full thickness tear, you can have a massive tear. Regarding the symptoms, you can have an asymptomatic tear or a symptomatic tear, and if you have symptoms, they can be pain, loss of range of motion, or loss of strength. So you have more or less 18 possible combinations of natural histories. So let's try to check one by one. The acute traumatic tear, you have an acute shoulder trauma, usually, with limited painful range of motion in a previously asymptomatic patient. So there's sparse information in the literature regarding acute tears. Up to 2000, there was only level 5 evidence studies. They told us that usually these tears can be treated operatively. They have this indication. This happened in young patients and active patients, and the repair should be done as soon as possible. From 2000 to nowadays, there's some more literature, level 4, nevertheless. What we know nowadays is that the mean age of these acute tears is about 54.7 years old. In about 0.5% of the cases, you have 2 or more tendons who are torn, and this kind of tears more likely involve the subscap. So what about chronic degenerative full thickness tears? Usually there's no history of trauma. This is a progressive tendon degeneration that usually comes from altered shoulder biomechanics. So what we know is that this happens in slightly older patients, mean age of 62.6 years old. In this paper, the authors evaluated 272 full thickness tears by ultrasound. They concluded that 1/3 of them occurred affected the anterior cable, and the majority of them occurred by more or less 13 to 17 millimeters posterior to the long head of the biceps. Also, they concluded, and more importantly, that the disruption of the anterior cable of the supraspinatus usually is related with degeneration, and larger tear size is related to infraspinatus degeneration. Fatty degeneration occurs almost exclusively in full thickness tears. So in this other patient, the authors evaluated 61 full thickness tears also by ultrasound with a minimum 2-year follow-up. And they concluded that 49%, about half of them, enlarged over time, and tear enlargement was related to pain development. Also in this another patient by Kinner and colleagues, they evaluated 118 full-thickness tears also by ultrasound. They concluded that at 2 years, 22% of them enlarged, and at 5 years, 50% of them enlarged. Tear enlargement was once again related to pain development and fatty degeneration. Almost half of them, symptomatic tears, developed pain, became symptomatic at 5 years. In this other patient, also by the same lead author, they evaluated 139 full-thickness tears, also by ultrasound, with a minimum 2-year follow-up, and they concluded that greater enlargement was related to the anterior cable disruption, and then pain, of course, was related to a decline in shoulder function. In this study by Hervet Davis, they evaluated 56 full-thickness tears, also by ultrasound, with a mean follow-up of 6 years. They concluded that 67% enlarged. Tear enlargement was related to fatty degeneration, and usually the time for degeneration in supraspinatus tears was 2 years, and in infraspinatus tears was 3.1 years. I'm sorry. In this paper by Moosmeyer, they evaluated 37 full-thickness tears, but by MRI, not ultrasound, with a mean follow-up of 8.8 years. They concluded that 50% of them had a positive tangent sign, and this was related, of course, to an inferior function. What about chronic degenerative partial thickness tears? So usually also no history of trauma, also comes from a progressive tendon degeneration and altered shoulder biomechanics. In this paper by Mike Kim and colleagues, they evaluated 88 rotator cuff tears by ultrasound, partial ones. They conclude that the most common location was 15 millimeters posterior to the biceps tendon. Keener, also in the same paper, evaluated 56 partial thickness tears also by ultrasound, and they concluded that at 2 years, 11% enlarged, and at 5 years, 35% enlarged, so less than chronic full thickness tears. This is a lot of information, I know, but I promise that at the end I'll give you like a summary. So in this paper, Maman et al., Maman and colleagues, they evaluated 49 rotator cuff tears by MRI. None of them progressed to fatty degeneration. And in this other paper by Dr. Mall and colleagues, they evaluated 30 partial thickness tears by ultrasound with a minimum follow-up of 2 years. 20 of them remained asymptomatic, 10 became symptomatic, like 1/3, and of this 1/3, 40 progressed to a full thickness tear. What about acute on chronic tears? Usually this is an acute shoulder trauma with a previously symptomatic patient, and usually these patients also have a history of a contralateral rotator cuff tear. So there's not a lot of evidence on acute on chronic tears. Some authors believe, and I think that most of us who have some experience treating these patients believe that most of the acute tears occur in a previously sick tendon. But there's not much evidence because it's very difficult to study this kind of tears. So here, I think it's very important to check the MRI, check the presence of edema, of effusion in a tendon that has signs of fatty infiltration or muscle atrophy, and this will probably lead us to this conclusion: this is acute and chronic. So, but how should we treat them? Should we treat them as acute? Should we treat them as chronic? We don't know, lack of evidence. So the final question is, what is your goal? What is your goal as a team between shoulder surgeon and patient? Do you want to treat your patient's pain? Do you want to restore some function? Do you want to restore perfect function of your patient? Do you want to gain strength? Do you want your patient to return to sport or to return to manual or heavy labor? These are they're very different kinds of goals. So you have to establish with your patient what is your goal. And why is this important? Because you adjust expectations from the beginning, you have a shared and an informed decision in order to get an optimized outcome. So we have to manage the expectations of the patient and of the surgeon, of course. So I promised you that I would give you a summary. So let's see, after squeezing all this dull information, what can we get from here? So what we know about from the literature is that acute traumatic tears occur in patients 10 years younger than chronic degenerative tears. Acute traumatic tears usually involve 2 or more tendons, and one is probably the subscap. About half of the patients with painful degenerative tears have a contralateral asymptomatic tear, and half of the asymptomatic rotator cuff tears will become symptomatic in a 5-year period. Less than 1/3 of the degenerative partial thickness tears will progress to a full degenerative thickness tear, and degenerative partial thickness tears have less tendency to enlarge than full thickness tears do. Fatty degeneration affects almost exclusively full thickness tears, and about 1/3 of the full thickness degenerative tears involve the anterior cable, and this is related to a faster fatty infiltration. If left unrepaired, half of full thickness symptomatic tears will enlarge in 2 years, so be careful. Tear enlargement will lead to a progressive fatty infiltration in approximately 2 or 3 years. Tear enlargement results in a painful shoulder, which will result, of course, in a decreased shoulder function. So as a take-home message, there are many natural histories of a rotator cuff tear. So try to identify what kind of patient and what kind of tear do you have in front of you. Know and explain it to your patient. So understanding the natural history of your patient's tear will make us surely better doctors, and explaining the tear-specific natural history to your patient will make him a better patient. Thank you very much.